Okay, I think we're going to go ahead and get started. Thank you for all of those that are able to attend on Zoom as well as here in the room. Dr. Mattoon and I have been honestly talking about this topic, oh my goodness, probably 9 months. And it's been a personal interest of our own just about how maternal mortality can be really impacted by our bias. And so we've been really kind of passionate about talking about racial bias and gender bias and just kind of how those impacts can really affect healthcare. And so we finally got it to it before she graduates and wanted to present on this. And hopefully this topic is very, very broad. So I will say that we're going to only kind of get the tip of the iceberg, but we hope this is kind of stimulating for discussion and also just thought, and that afterward, this promotes you guys to kind of inquire about your own implicit bias and kind of rethink some of the stuff we do. Our objectives today are to really go over what implicit bias is, the impact on maternal health, a bit on some race and gender bias data, and then we are going to hit on some steps to combat implicit bias, because of course we want to have some action items if we can. And then at the end, we have a case study and reflection piece too. So hopefully our video works here. If it doesn't, please let me know. But we're going to listen to this video for just about 3 minutes. So not even. Oh, there it goes.
Okay.
Hold on 1 second. We know. Let's see if my volume here in the classroom. See if I put that up, it'll help. And try that again.
This is really good.
Oh.
My daughter's name is, his name, second pregnant.
Okay, we're cutting out.
We're excited. Find out.
I think that's gonna. Yeah, I don't think that's gonna work. Well, that's unfortunate. Yeah. I don't have the link right now.
If you hover over it, like you just were, get it expanded out.
Yep.
How it was when it was
Mhm.
at the very bottom right.
Over
Yeah,
here.
that's or bottom line. Yeah, right there.
Watch on YouTube. Okay.
Right up there.
Awesome. Josh, helping me out here.
Yeah, you know, I'm just like, this is really good.
Still.
Zion and
Oh my goodness, it's really coming across like
pregnancy. No, we were excited.
that's not going to be good. Okay, guess we can do that. I'm not sure if those on Zoom, are you getting the same thing? I'm guessing that.
National birth.
I'm maybe not.
Comment so.
Well, unfortunately, that's not coming through well. I would encourage everyone to Google CDC Hear Her campaign. There's about 10 videos of patients. We liked this video a lot. They're all women that are speaking to the fact that we are not often listening to our patients and that can impact their care. And so kind of draws in why this is important, and what we are about today is really hearing our patients and listening to what their needs and concerns are. And so there was a quote that we found in all of our stuff that we thought was really pertinent, that we don't see things as they are, we see them as we are. And so I think we need to think about that sometimes the perspective we bring has us viewing things a little differently. So go. Sorry, PowerPoint. Okay. So for the last 30 years, really implicit bias has been studied, and they've demonstrated that there's an automatic cognitive process that shapes our behavior, beliefs, and attitudes. And that's really what implicit bias is. It's an unconscious bias. And it derives from our ability to rapidly find patterns in small bits of information. And some of these patterns emerge from positive or negative attitudes and stereotypes that we develop about certain groups of people and form outside of our own consciousness. So this starts at a very young age. And these attitudes and stereotypes affect our understanding, actions, and decisions kind of in an unconscious manner. So a lot of times people say, well, I'm not biased toward a particular group of people, but this is just what we've been around since we were little. And so unfortunately, it's not even really we're conscious of how we're viewing people in that way. At best, these cognitive processes actually help us, what they say, efficiently sort and filter out perceptions, but they unfortunately can promote inconsistent decision-making, and at worst, they can cause systematic errors in judgment. And that's really what we end up seeing in healthcare. So we may be listening, but are we really hearing because of this bias? That's the question. So how does this impact maternal health? We do know that our maternal mortality rates, as Beth showcased in OB-Ed last month, has really worldwide has decreased, but in the US, our maternal mortality has increased by 50% in that same period. And we know that 700 women die each year due to pregnancy and delivery-related complications. And the really scary stuff is when you break it down by race, because the difference is astounding. So white women, there's about 13 deaths per 100,000 live births. In Black women, it's about 41 deaths per, that should be 100,000 live births, sorry. So that gives Black women 243% more likelihood than white women to die of pregnancy or childbirth related causes. And that should make us all upset. That's alarming. And we also know, and Beth pointed this out last time, that 3 in 5 maternal deaths are preventable. So when we're looking at our mortality rate, especially here in the US, we really have a lot of work to do. And a lot of what's coming out in the literature right now does have to do with, like, what are the individual factors that impact that maternal mortality rate? And implicit bias keeps coming up because we do believe that that's significantly contributing to this alarming kind of health disparity among the races. The concern is, you know, a lot of times there's been this thought that, well, it's the disadvantaged or uneducated, that those in a different race, that are African-American, Hispanic, et cetera, don't have the education, they don't have the resources. We talk a lot about access to care in maternal health, but unfortunately, that's not really what's bearing out when you look at the data. This is a New York study, they studied for 4 years, and they looked at maternal morbidity, and this one graph, they did a lot of dissecting of their data. But as you can see that Black non-Latina women in every group of education are
I'm putting them on.
Whoa. Hey, Max.
Oh, sorry.
Gotta mute, Max. And so,
Well, at least I know my button.
yeah, your mic's working, Max. We're good. And so I think that this is what's alarming. And we've seen this locally. We talked about the unfortunate death of the pediatric resident down at IU, African American woman, in the fall. We've seen that with other people, and we'll kind of have a slide here. And so some big names we know about, Serena Williams and Beyonce, were affected during their births with complications, some very serious complications. And, you know, they are well known, and you would think that just by who they are, that nurses and doctors would, I hate to say it, bow down to what their needs are. And take care of them and, be ready to go. But unfortunately, in both of their cases, they were not heard. Fortunately, they were able to finally get someone to listen to them and take care of their needs. But I don't know if you know their history, but Serena has a history of blood clots. And so she suffered a PE after her pregnancy, after her delivery. She knew what that felt like because she'd had them before. It was part of her medical history. She voiced that concern to the nursing staff and the physicians. Hey, I feel short of breath. Hey, I have chest pain. And the doctor didn't, all they wanted to do was a lower extremity Doppler. They weren't going to do a stat chest CT. They weren't going to evaluate further. And so again, the nurse, there was a quote in an article, and the person writing the article said she told a nurse between gasps that she needed a CT scan with contrast and a blood thinner. But the nurse thought Williams pain medication might have been confusing her. So even someone as, I say, powerful as Serena Williams can't be heard. And so it's a real problem. And there's some links to articles. If you've not dove into some of those, I think they're fairly interesting to kind of read about. But this is a real problem, and not just of disadvantaged or poor African-American women.
Just a little bit shorter. I don't know if I'm going to be able to pull this off. I'll stand on tippy toe. So one of the things that I find really interesting about the topic of racial bias and gender bias is actually from my background in undergrad, where I majored in anthropology. And one of the things that really stuck for me from my educational experience there was that we really talked about how race is a social construct. And so I feel like sometimes we don't really dive into that very well during medical education, and we felt that it would be an appropriate thing to give just sort of a primer on or a refresher on. So this is a quote from one of the guys who's responsible for the Human Genome Mapping Project. He noted, "Race is a social concept. It's not a scientific one. There are no bright lines that would stand out if we could compare all the sequenced genomes of everyone on the planet." He also said, when we try to apply science to try to sort out these social differences, it all falls apart. And so that really kind of underlines this idea of race as a social construct. It's a concept that we've used to create this sort of understanding or pattern recognition to this objective reality that we think we're experiencing. But in reality, we've created it as a result of the social functions that we've both learned and that we've perpetuated. And so just to kind of highlight that a little bit more, the Human Genome Project or mapping showed that the genetic variation within the human species is on the order of 1 to 3%, and that the types of variations that we see do not support the notion of genetically defined races. If you've ever really looked into this or learned about this in medical education, the concept of race really came about through some very faulty science. We start to talk about things like eugenics. We start to talk about things like pseudosciences, like phrenology, where people would try to ascribe differences in populations to this concept of this race. But realistically, those differences that we see are more accurately ascribed to biological concepts of evolution when we're talking about how populations start to settle into different area and have evolutionary differences that result from their population changes. But the actual concept of race itself is how we look at those changes and we provide and describe these differences and maybe ascribe value to them. Okay. So some other concepts to kind of be aware of when we're talking about the concept of race. There are a lot of different ways that race impacts the way that we're going about the world and with the way that we learn about the world through our culture. One of those concepts is structural racism. It is the way in which a society creates or fosters racial discrimination through mutually reinforcing systems such as housing, education opportunities, media portrayals, employment, or healthcare access. It is an imbalance of inherited resources and persistent discrimination that can restrict many people of color's access to better jobs, their quality of education, et cetera. And then structural racism can create and strengthen both explicit or implicit discriminatory attitudes and behavior. And I wanted to throw this concept in here as well. The concept of enculturation, that is how you learn the things that you learn and how you walk through the world. So you don't come into the world with this set of beliefs or norms. They're taught to you by your friends, your peers, your family, your educational system. That's enculturation. And that is how, when you go from the American culture to, let's say, the Indian culture, or one Indian subculture, you are experiencing the world through your lens instead of theirs. And so you're still ascribing your value, but they learned a different set of values and beliefs and customs. So enculturation is that gradual acquisition of characteristics and norms of a culture or group by a person. I included this slide to kind of prompt you to ask yourself some questions. I think, and this is a really powerful exercise that I've experienced way back in my undergrad experience, but when you look at all of these women, do you automatically start to ascribe racial characteristics to them? You don't have to answer me, just kind of think about that. When you look at this group of women, do you automatically assume or make value judgments such as Black or something along those lines? And if so, I would challenge you to kind of reconsider that as far as like the racial definition of a Black or African American, many of these women are actually of different ethnic descents. So this individual here is from Papua New Guinea. She would technically be Melanesian descent. These two women are both from India. And obviously there are a lot of different ethnicities at play here. This is a very, very simplified view of the concept, but the whole goal here is to look at these women and recognize that while you may be able to ascribe definitions or values or make quick judgments about who they are or what they identify as, you may not always be correct. And that is really a powerful aspect of this concept of race and racial bias. So going further into this concept, race is both not biologically real from like a genetic perspective, and yet it's an incredibly socially and politically real system that we've created. And because of that, we are definitely experiencing the reality of race in our job as a healthcare team or system. One really great example of how this social construct can play out is the idea that Black women have higher rates of preterm births. I think we've all heard that. We all take that and we understand that as a fact. But realistically, when you start to dive a little bit deeper into this concept, you can recognize that preterm births are 60% more common with Black babies than white babies. But there are some reasons that go into that. One study did show that chronic stress was the primary reason for this disparity. So not necessarily the identity of the mother, but rather the situation in which she was living in or experiencing. And then other studies have shown that that stress can be transmitted from generation to generation. And we've really started to talk about the role of epigenetics when we talk about shared trauma or generational trauma. And I think that this is a great example of that. So really the thought is that in this case, when you're looking at race as a social construct and you're looking at this fact that we have, that Black women have a higher preterm birth rate, it's that Black women aren't more likely in and of their innate selves to have that higher birth rate or their innate population to have that higher preterm birth rate, but that they are more likely to experience that because of stressors like racism or poverty or lack of access to care that disproportionately affect the population that they've been identified as being a part of. So a call to arms on this would be that we really have to de-emphasize race in terms of how we provide healthcare and how we classify and assign causality. But at the same time, we have to be aware of and we have to emphasize the fact that race is impacting structurally and institutionally, or the concept of structural and institutional racism is very much impacting our patients and leading to these health inequities and these differences in outcomes. One of the other common biases that we'll see, and obviously this certainly applies in maternal care, is gender bias. So this is the idea that a prejudice or treatment against a person is created or carried out on the basis of their sex. And in healthcare, it refers specifically to situations where patients are assessed, diagnosed, and treated differently and or at a lower quality of care because of their gender than others with the same complaints. And in healthcare, it can manifest as the assumption that all presentations are the same between male and female. And so that these differences, there are no real differences in how someone should receive care. There are some striking examples of this that I think we're all fairly familiar with, the most common being cardiovascular disease. We know that MI or cardiovascular disease is a leading cause of death in women, more so than in men. And part of that is believed to be because the classic medical education focus for MI recognition and treatment has been on those classic symptoms of substernal chest pain, radiating into the left arm, potentially up into the jaw and back. And those are, maybe associated with diaphoresis. Those are classically male symptoms of an MI, while women may have atypical chest pain symptoms. And those atypical chest pain symptoms are not as commonly or as well taught in medical education. And so they often go unrecognized. So a woman could present with nausea, and that could be her hallmark symptom for her MI, but because it's not a commonly taught symptom, people don't necessarily recognize it. What's striking about this is that when women are appropriately identified and they receive the exact same care as men do, their survival rate is the same. But for right now, that is not the reality that we're living in. Women are not being recognized and they are not being treated consistently as men are, and so they're not surviving as well. Other well-known examples of gender biases include mental health. Women are more likely to be treated than men. There is some thought that there could be a cultural process at play here where women are taught that they are supposed to be in that emotionally vulnerable or open frame, whereas men are taught maybe that they need to be a little bit more closed and to not necessarily recognize or be vulnerable. And so there's that aspect to this. And it's interesting because when you actually break it down, the differences of depression prevalence and incidence don't necessarily vary a whole lot. And then the other thing that I think a lot of us have probably seen or maybe seen at play is pain management in male versus female populations. Women are more likely to have significant delays in the treatment of their pain. And female-specific chronic pain conditions are historically under-researched and under-treated. And some really great examples that I think a lot of people here will recognize are PCOS and endometriosis. We now are starting to recognize, in particular with endometriosis, that can be a cause of some very significant chronic pain for women. It can be very debilitating, but the evidence for that has likely been in front of us for many, many years, and we just haven't really taken that into consideration. So knowing that those are two of the very many implicit biases that we may carry when we go to take care of our pregnant population, what can you do about that? Obviously, we're not expecting you to suddenly be like this woke social justice warrior when you walk out of this presentation, because this is just kind of a drop in the bucket of what to do and how to deal with this. But we want to provide you with this tool to be able to sort of recognize and maybe start to reflect on how you as a physician or provider and your team can start to think about, reflect on, and maybe make some changes in this area. One tool that we found that was really helpful to us, it's a little bit lengthy, so it's maybe not helpful on the fly, but was this tool that was in the Family Practice Management journal recently, talking about specific strategies that can be used to combat implicit biases. And they very helpfully created a mnemonic that stands for implicit. That I don't know about you guys. When I look through it, I'm like, I don't think I'm going to be rolling that one off the tongue anytime soon. So we'll run through it. The idea is more that this is supposed to sort of start that process for you and help you to start thinking about and reflecting about this. But the first item that's on there is introspection. That would be the I of implicit. And this is really just an opportunity to explore and identify your own implicit biases by taking or reflecting through things like the implicit association tests. There are a lot of other resources that are available to do this, but this is one that is really well known. So Harvard created this IAT implicit association test to create this sort of series of free computer-based exercises that you can go through. I did this way back in the day when they were first starting to advertise this, and it was really only based on racial biases at that point in time. And it was a really good, I think the really important thing to recognize about this is that it's not necessarily a one and done, you look at this and now you know exactly where all of your biases lie and what you need to do about them. It's more of a reflection prompt sort of tool. So in that moment in time, when you're taking this IAT, it's providing you with a snapshot of what you're thinking and feeling in that moment. And so it's really more of a reflection tool than it is any kind of rigidly structured, scientifically validated tool or assessment to tell you just how much of a racist you are. So it really is very helpful. I was surprised when I took mine. I feel like my background in anthropology sort of really shaped mine in a way that I wasn't expected for. I found that I had biases that I would not expect for a white female to have. And so that was helpful for me because I actually learned that I needed to reflect on some of those things and make some changes. But it's a pretty good tool for taking that moment to reflect. And they have several different versions of it now. I did one on religion recently. There's some on gender biases. There's some on race. There's really a lot of different things at play there that you can evaluate. The M in implicit, it stands for mindfulness. And so one thing that's been shown is that if you take the opportunity to practice stress reduction or mindfulness techniques, including yoga, you will actually decrease your natural tendency towards bias. So there's an article here from the Greater Good Institute at Berkeley that kind of talks about how that's the case, and definitely worth reflecting on and maybe making this part of your practice if that's a concern of yours. Perspective taking, considering experiences from the point of view of others. I think that really this is just talking about practicing and actively practicing empathy, making sure that you're looking at media and reflecting on that critically, and understanding really what that media is portraying, both positively and negatively about someone. And New York Times also had a great article on this, and we will make sure that we give you guys these slides too so that you can access these links and such. And then L, this one again, rolling off the tongue, learn to slow down. I feel like this might be the hardest one for people in medicine to do, learning to slow down. But this is really taking the opportunity to pause and reflect on your own biases before you go and interact with someone. And I think that this is probably one of the harder things that they ask you to do in this mnemonic, to take a moment and just pause and reflect before you walk into that room with someone whose identity you may assume is much more or is much different from your own. I really enjoyed the example or the resource that they gave with this. They basically included the snacks and punishment video, and I watched it and I got a really good giggle out of it. I mean, it's kind of terrible, but hangry people, hangry judges were more likely to give the people in front of them harsher sentences. And it was just kind of evidence that stressors, including long hours, not taking breaks, not treating your own person as a person, was more likely to cause you to lose empathy for others and to start to really buy into biases that you may have.
So the Snickers commercials are completely true.
Yes, the Snickers commercials are true to life, true to form.
Telling you to have snacks at all times.
At all times, snacks. Yes, you could also consider bringing food every time you go to a doctor's appointment or having kind of legal situation that you're involved in, definitely. Oh yeah, Dr. Witt brought up when little kids bring apples for their teachers. They probably have tapped into this secret. That's why they're really getting A's in all their classes. The next I is individuation. So evaluating people based on their personal characteristics rather than those affiliated with their group, including connecting over shared interests or backgrounds. I think that this one really requires you to have the wherewithal to make sure that you're sitting down and really getting to know the person in front of you. And sometimes I think on the OB floor that can feel like a little bit of a challenge if this is a triage situation, or if someone is coming in and maybe they're rapidly progressing and you've never met them before. You know, having the ability to really sit down and connect with them over something might not really be feasible, but I think there are a lot of other opportunities and times where you really can tap into this and make sure that you're trying to understand that person for who they are and not for who you perceive their overarching group or population identity to be. Check your messaging. So embracing evidence-based statements that reduce implicit bias, such as welcoming, embracing multiculturalism. I thought that this was really interesting. The impact of multiculturalism versus color blindness on racial bias. I actually had a friend who posted something on Facebook the other day that was a really powerful meme, and I wish I would have grabbed it and saved it because I couldn't find it later, but it was two people holding up signs. And one of them was, "I don't see color." And they had these swatches that were all just like this light blue. And then the headings under those two groups of light blue swatches were people who experience like police brutality and people who do not. And then they moved and they had the second poster, and it was, I recognize that race is a problem, and it had those same two headings, people who are brutalized and people who are not, and it showed the skin tone kind of representation of that. And I thought that that was a really powerful example of what this is kind of saying when people say, well, I don't see color. You're kind of going too far to the other extreme of saying that race is not a social construct that has very legitimate and very serious consequences to it. Institutionalizing fairness, so promoting procedural change at the organizational level. There are a lot of things that have been done, but there are way more that need to be done. And there's a lot more just identification and creating opportunities to make that change. And I think that that's something that we, as the current generation of healthcare providers and physicians, are really responsible for, is finding that opportunity to help recognize and create systemic changes. And then take two. So this is practicing cultural humility, which is a lifelong process of critical self-reflection to readdress power imbalances of the clinician-patient relationship. I'll be honest, I feel like this is the only thing out of this entire new life that I catch myself doing and trying to do. So that just goes to show you, as someone who's like, I really care about this and I want to be invested in this, but there's a lot of work that you have to do. And when I consider myself to be someone who is trying to do this, this was the only thing that I really recognized myself doing on a regular basis, which was before I would go in and talk to someone, or maybe even while talking to someone, kind of checking in on myself and recognizing when I wasn't providing them with opportunities to connect with me, or if I was applying that stereotype or not listening because of that. So I do think that this is really hard to do, or at least it's very hard for me to do, but I would challenge all of you to kind of take a moment when you're sitting in a room with someone and you're frustrated with them, and maybe they have a different experience of the world than you do, that you kind of pause and reflect on why you're frustrated with them or why you're not understanding where they're coming from. So we're going to switch to a case study kind of discussing some of these concerns with implicit biases.
This actually this case came from the Everyone Project, which is through the AAFP. There's an excellent toolkit there on implicit bias training. And so it was OB related. So we thought this was a perfect opportunity to share this case. So I'm going to read through, there's a number of slides, but I want everyone to kind of think about how real this case is and how other situations you've been in kind of relate to this case. So we've got Tasha, she's a 22-year-old G2P0101 African-American woman at 24 and 4 weeks, brought into triage by ambulance for severe abdominal pain and back pain and reports of contractions. She arrives to L&D in significant pain. There's a primary nurse, nurse number 1. She's very attentive to Tasha and seems very concerned, but the second nurse, nurse number 2, is more experienced, seems distracted and unconcerned when she meets the paramedics in the triage room. After the paramedics moved Tasha onto the triage bed, the nurse number 2 asked, "What made you call the ambulance?" Tasha says that she doesn't have a car and she's been having severe pain in her lower abdomen, pelvis, and back that comes and goes like contractions. So the first nurse puts Tasha on the monitor, places her hand on Tasha's abdomen. She's less experienced, so she's really not sure if she's feeling contractions, and Tasha's only 24 and 4. So she turns to nurse number 2 for confirmation. The more experienced nurse palpates for contractions for about a minute and tells Tasha, "I don't feel any contractions, but we'll watch you on the monitor for a while." Tasha tells both nurses that she thinks she might be having some discharge or leaking fluid. She says, "It started this morning, but there's no bleeding," and neither nurse does a cervical check. They ask Tasha about drug use, domestic violence, and whether she is with the father of the baby, and they ask to collect a urine specimen. They obtain a verbal order for acetaminophen and hydroxyzine from the laborist who's attending because the resident is finishing with the delivery. 20 minutes later, the resident has finished the delivery and is informed by nurse number 2 that Tasha needs to be seen. That nurse says she took an ambulance here because she thought she was having contractions, but she isn't. No contractions on the monitor, and I don't feel any either. She's having some discharge and probably has BV. I don't know why these people always have to take the ambulance here for stuff like this. She could have gone to the clinic. Sound familiar, right? The resident's only on the second week of L&D and is inexperienced. During an extensive interview, Tasha tells the resident that her first baby, which she had about a year ago, was at 36 weeks, born at 36 weeks gestation. The resident asked Tasha if she's been on progesterone, but Tasha doesn't know what that is. She doesn't think her physician ever mentioned it to her. Interestingly, in Tasha's prenatal record, the resident finds a note from her outpatient physician stating that Tasha did not have reliable transportation and hinting that Black patients were almost never consistent about coming in for injections. The physician opted not to initiate progesterone. Tasha continues to be in pain. However, per the nursing staff who saw her right after she came in, she appears more comfortable after the Tylenol and hydroxyzine. She does not have any contractions on hypometry, although no one has palpated her abdomen since she initially arrived about 75 minutes earlier. Tasha tells the resident about her vaginal discharge and that she is possibly leaking fluid. She confirms that she does not use drugs or alcohol. The resident leaves the room to have the nurse collect supplies to do a pelvic that includes a ROM plus, fetal fibronectin, wet prep, and GC chlamydia. During this time, a code blue is called to Tasha's room. The first nurse in the room, when Tasha starts having significant abdominal pain, yells, "I need to push." The resident and many nurses run into Tasha's room to discover that Tasha has delivered onto the bed. The resident clamps and cuts the cord and rushes the baby to the warmer just as the NICU staff arrives, including a neonatal doc who happened to be in-house. They start resuscitation immediately, including intubation and administration of surfactant. Tasha's infant girl, Lily, is able to be resuscitated and remains in the NICU with assisted ventilation and blood pressure support for the next 5 days. However, she suffers a grade 4 intraventricular hemorrhage and bilateral pneumos. On her 6th day of life, Lily has increasing oxygen needs and pressor support, and her mother opts to withdraw support, and Lily dies. So that was a pretty powerful example, and I think, unfortunately, when Jocelyn and I talked, seemed very, very, very real. I can personally recall situations where things were overlooked, and sometimes not even at the time that I recognized that they were overlooked, but they were just pushed aside because of not necessarily even race. I think a lot of times our bias has to do with populations of individuals that are disadvantaged. I will say drug abuse individuals that are either on MAT or having opioid use disorder problems, I feel like get overlooked and they're not heard. And so this obviously case brings to light that this premature birth and neonatal death really happened because of confirmation bias, anchoring bias, and conformity bias. So there's a lot going on with the biases that we see, and whether it had to do with what the nurses, the thing that I recognized the most was just the passing down of the bias, unfortunately, because we had inexperienced people kind of getting confirmation from someone that supposedly had more experience, but then unfortunately another inexperienced person was brought in and they were passed on that same poor message. Kind of that telephone game was really bad in this situation because it was like, oh, she's not having this problem. Because obviously she was contracting, she was having worse problems. So some more discussion. The outpatient physician assumed that she would not comply with her progesterone therapy to prevent a preterm delivery due to her race and socioeconomic status. As a result, she wasn't really even given information, and that was unfortunate. The second nurse had a confirmation bias that she was not feeling contractions because she didn't see contractions on the monitor, but we were at 24 and 4. In addition, she didn't believe that Tasha was having contractions because she had an anchoring bias that these people use ambulances in non-emergent situations. And I know I've heard that statement before in my medical career. The first nurse was affected by conformity bias because she, of course, asked, she was concerned. So she did have that initial concern, but she was allowed, she allowed nurse number two, the experienced nurse, to influence her own assessment. And I think that happens rather often. And the resident was also affected by conformity bias because they delayed an exam based on the assessment that the patient was less urgent than they really were. And so unfortunately, the situation kind of ended with all of those affecting Tasha. So as we're kind of ending this, I know we've got some time, and it was intentional to leave some time for discussion, both from the folks on Zoom and the folks here. But here's a couple questions. I'm sorry, I've left this thing up over here all the time. But a couple questions to think about. You know, can you think of a time at work when you have encountered or observed implicit bias, whether it's one of those particular biases or not? If you, as an upper level or an attending, had an intern come to you with concerns about the potential impact of implicit bias on a patient's care, what advice would you give them? How would you work through that? Have any of your patients been impacted by implicit bias by the care team? And again, none of these have to be discussed, but just really want us to think about it. And then, you know, also if you observed an intern whose patient treatment raised your concerns, and this could be observed any one of us, honestly, concerns for possible implicit bias, what would you do? And what if it was an attending or an upper level and you were in that role? So if anyone feels comfortable discussing, or if you have other points that you want to bring up, we'd like to have this opportunity. We do have our reference slide. I will highlight both the Hear Her campaign on the CDC, excellent videos. They're just like 3-minute long. I really emphasize that's a great campaign. I told Jocelyn, I feel bad that I didn't hear about it before researching some of this. So I feel like we definitely need to get that out. And then the Everyone Project at AFP. I'll be honest, after reviewing it, I feel like we're going to get more of that into our longitudinal curriculum. There's a lot of good stuff in there. And then, of course, some of the other stuff Jocelyn shared on race as a social construct and the articles on Beyonce and Serena Williams are impactful. So I'll kind of go back to these questions. Both Jocelyn and I can answer, so we'll try to monitor chat here too.
I'm willing to start if anyone else isn't. I actually have been in a situation very similar to the case study with Tasha, where I was told this patient just has EV. Why are you ordering this workup? And unfortunately, that patient didn't look like me. That patient had a different experience of the world than I did. And I definitely felt like it was very difficult to convince my team that we needed to get a ROM plus on that individual. And it was positive, and it really could have very negatively impacted her care. And I don't think that there was anything malicious about it, but I do think that that's that example of implicit bias really impacting how you're willing to perceive someone's story, how you're willing to provide care for them. So reading that and seeing Tasha's case study, it was not so much eye-opening, but confirmation that I've seen this in action. Anyone else have anything they want to share or thoughts on any of this?
Maybe have patients be well composed enough and physically tough enough that if there's any complaints, I didn't take it seriously because I think you seem to be handling it well. But what they told me is severe low back pain contractions, and just because they appear to be handling it well doesn't mean you should listen to those complaints and pursue the work of the court.
Dr. Field mentioned, for those on Zoom, that he's had patients that even given some severe complaints appeared to be handling those complaints okay. And so he feels that he may not have been working things up quite as well because the patient themselves are they're saying they have severe back pain, but they appear to be handling it well. And again, that's maybe a bias because we all have different pain thresholds. So we need to be aware of that too. But I think that's a good point, is that sometimes we walk in expecting severe pain to look like something, and it doesn't, because severe pain for me looks like something and it looks totally different for someone else. We also have to understand that some people are in severe pain, or at least chronic pain, every day. So having pain doesn't necessarily make them look like they're having as much pain. So, and that's something that's really important. That's a definite bias that we see.
I think from like a cultural perspective too, if you think about depending on where that person was from, it might not be socially acceptable for them to display the way that they're feeling on a pain perspective. And then additionally, how are we taught within our own culture, sort of the pervasive American culture, that women respond to pain? Is it that historical concept of hysteria? And then when you think about that, what kind of stereotypes or biases do you apply to that? A woman with hysteria, probably you can go two different ways with it, right? Like, oh, she's just overplaying it. It's that hysteria, she's fine. Or if a woman presents and she's not in hysteria, I'm going to undercut or assume that there's not a whole lot going on here. So it's a double-edged sword, but I think that that's something that culturally a lot of us have been taught.
One concept that we talked about and we ended up not including is the concept of thinking that when we interview and interact with our patients, what if we pretended there was a curtain there, right? And so in medicine, we typically go in, we pull the curtain, we see the patient, we talk to them, we look at them, we make judgments based on what we see in front of us, which the physical exam component is very important. But the assessment and the hearing of their story and their complaints doesn't require us to see them. And what if we thought for a moment that we kept the curtain closed, we listened to them, we made those assessments, we tried to figure out what was going on before we viewed what was behind the curtain. I think, in all honesty, there would be some changes in how we took care of that patient. And so I do feel like there is something to be said about thinking about keeping that curtain closed when we're assessing. And again, probably not going to do that. The patient will think we're odd. But if we closed our eyes for a moment and we really thought about who is telling me the story, and who is really, what are they telling me? What do I hear in their voice? What do I hear in their concerns versus what do I see? Do they look like Jocelyn said, in hysteria, or are they texting? And I've been known to say before, oh, she's not in much pain, she's sitting in there texting. Well, she might be in more pain than we give her credit for, and that's her coping mechanism right then. I don't know. I have definitely delivered some babies that the woman made very little peep with no epidural because she was very internally able to control that pain and deliver. And you would never have known that woman was in really active labor. I don't know how those women do it. I'm always in awe, but that woman doesn't have any less pain necessarily than another woman. Their just way of dealing with it is different. And so I do think we want to just think about it. I think it's something that we all need to reflect on. We hope that, I'll send these slides out. We hope that you guys can maybe read an article or two, bring it up. The Green Journal, I get it every month. There's a great article in this volume from May. There's an MFM that wrote a perspective article. I see you, I hear you, only then I speak. Briefly, they talked about really looking more at the palliative care perspective of getting history, which is ask, tell, ask versus tell, ask, tell, meaning we ask what the patient's biggest worries are. We ask what matters most, right? That's the IU health kind of value, and it's been really pushed right now. We ask that first, and then we tell them medically what may be going on and try to fit that into what their values are for that case, for their care, and then ask again, are we addressing those values? So I think that's something, and that literally just came out and I read it this morning and I was like, oh, this is perfect. but that kind of plays into how one way to think about combating our bias is really asking about and getting to know our patient first, right? If we get to know that patient a little bit more, it's less about what they look like and less about what where they're raised and all of that, but more about who they are. And we make a lot of assumptions about what they need in their care or what they don't need in their care, i.e. we don't get the things they need and they deliver a preterm baby. So
I'll throw out there too, I don't have much experience with the OB world of implicit bias, but you guys have already listed out a lot of great clinical fixes for implicit bias, but a big part of the fix is not happening in the clinic, it's happening in the community. Remember that as family doctors, that the community, huge part of this. We have to make our votes count, make our wallet count, make our community count, and that is a big part of literally saving lives and making sure that your patients feel comfortable with you. Being on the community is really do that.
I'll restate, Dr. Rainey made mention that one other way to combat implicit bias is really being out in our community, and that reemphasizing that it's really important to be aware of who we're voting into offices and what we are promoting in our community and how we are promoting basically, better treatment for the groups in the community. So I do think that's important too. Lauren. We could do it through the video. I know that that's one option. Yeah. Lauren, Dr. Janagi's made a good point about being cautious or being aware of when we're using translators. So if we have a patient that is not English speaking, we do need to make sure that we are including a translator in their care and not assuming that the folks that are in the room with them are able to adequately translate. And she's had an instance or two where that has been impactful for the patient's care. So I would agree with that. I know it adds more time. I would agree with if you have someone that's Spanish speaking or speaks any other language than English, that we would need to add more time to a clinic visit. That's a very reasonable ask. And so I do think it's something to plan ahead, look at your schedule and make sure that we do have the option now with video visits, and I can help. We're going to start rolling that out with the embedded virtual care in Cerner that we're going to roll out here toward the end of this month, that you can do a translator on that service too. And that will help, and both the translator and the patient and the doc can be on the same screen. So I think that will improve at least maybe some communication that normally would not have happened verbally, because you can't make the phone call as easily as you could maybe do this video visit with them. So.
What other thoughts and reflections do people have? I don't know if they can hear me. What other thoughts and reflections do people have either on these questions or on the case study that we presented or any of the terminology that we use today? Really like to hear people's thoughts or experiences before we wrap up in the next couple minutes.
So Sarah brought up she finds one of the biggest challenges, but it's also one of the biggest, I say imperatives, is to confront our colleagues when we see implicit bias or biases coming out in their care or their interactions. I would agree with that. It's difficult. And so I think it is something that we all have to kind of hold ourselves accountable for. But also, as professionals, really understand that someone may notice that in us. And again, when we think about implicit biases being in our subconscious or unconscious, it's going to be obvious that sometimes we don't know we're showing those, and that someone else may notice those, and that's okay. And that we should all be aware that we want to improve. And so I think it's very valuable to work together to talk about these things. I think the more we have a language about it, the less it's going to be attacking. And the more it's going to be about really helping each other improve and take better care of our patients. And say, any thoughts from the Zoom folks? We appreciate your attendance.
Hi, this is Eric. I was just gonna mention again that, can you hear me?
Yeah, I think.
Okay. I was gonna mention again the Project Implicit that Dr. Mattoon brought up. That is a fantastic way to examine our own.
Cutting in and out, Eric, unfortunately.
Let me put it in chat.
If you're able to type something in the chat, that may be a long statement. And I know we're kind of at the end here. We're having our technical difficulties today. We definitely appreciate, I will be sending these slides out to everyone that got the Zoom invite. And we'll have this recording if anyone needs to reference back to it, but we appreciate it. Look for things to get yourself thinking along these lines. Eric said he encourages everyone to use the Project Implicit to explore their unknown biases, and I would agree. I definitely did it myself. I realized that I, strangely enough, put women not in science as much as I put men in science. So I did that little bias, and I was like, what? Yeah, I was really mad at myself. So I'll be honest. I was like, I am not okay with this, but that's okay. So guess what? As a woman in science, I guess I don't see myself in science. I don't know. So, okay, thank you, everyone.
So